Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome to the channel of Stand Medical Notes. So we'll continue the topic of acute coronary syndrome. So in the previous class, we have discussed about the ST segment elevation myocardial infarctions, that is STEMI. STEMI. We have not discussed about NSTEMI, non-ST segment elevation MI, or unstable angina. So we'll see 1 to 2 ECGs of those NSTEMI. Okay. So let's begin with the name of Almighty. So these ECGs, these two ECGs, one by one we will see. So this is the first ECG. So you can see here there are ST segment depressions. First you see inferior leads 2, 3 AF. There is ST segment depression. There is ST segment depression in 3. There is ST segment depression, but there is no T wave alteration. Okay, T wave is normal. Okay, and how do you say that it is ST segment depression? There is J point depression. So if there is no J point depression, there is no ST segment depression. Remember this point. So depression elevation is what do you call, the parameter to assess depression or elevation is the J point. Okay, if the J point is depressed, ST segment is depressed. If the J point is not depressed, ST segment is not depressed. So here you can see there is depression of J points in these leads 2, 3 AVF, and also you can see in V4, V5. Okay, V4 and V5, mainly in 2, 3 inferior leads. You can see ST segment depression, but there is no T wave inversion. Okay, so this means what this means, and the ST segment depression is downsloping. This is also important. The ST segment depression is downsloping. Okay, so remember when I said in the previous classes, in ischemia or infarction, the ST segment should be, it will be either downsloping or horizontal ST segment or downsloping. If it is upsloping ST segment depression, then it is not ischemic, or it is benign mostly. It is mostly benign. So here you can see there is downsloping ST segment depression. So what inference you draw from this? What conclusion you draw from this? So either it can be ischemia, or it can be NSTEMI, non-ST segment elevation myocardial infarction. How do you confirm that? You send the sample for troponins. If troponins are elevated, if they are elevated, then it is infarction. If troponins are normal, then it is ischemia. Okay, then it is ischemia. So that is one ECG of ST segment NSTEMI. Second, we will see. Okay, second we will see now. This is the second ECG. So what are you seeing here? There is inversion of T waves as shown by this arrow marks. See this T wave, 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 see this. So these are inferior leads, 2, 3 AVF. These are inferior and these are lateral leads. These are lateral leads and these are inferior leads. So along with the T wave inversion, you can also see slightly ST segment depression also you can see. Okay, there is ST segment depression also. Now, what is the differential diagnosis of only inverted T waves? If there is ST segment depression, it can be ischemia or infarction. How do you differentiate by troponins? So what is the differential diagnosis of symmetrically inverted T waves? So we have discussed. That's why I think many of the learners or teachers, I can say, they have not seen that detailed videos on the T waves. That is very important, very important, because T wave changes are very common in ECGs. Okay, so if we don't recognize that, there will be referrals, or there will be panics by the doctor itself. The doctor itself will panic first. Okay, so that's why that in knowing the importance of this detailed information on T waves is important. So what is the differential diagnosis of inverted T waves? First of all, if the patient is symptomatic with this ECG like inverted T waves, just send for troponins. If the troponins are positive, then he is saying NSTEMI. That's all. If the patient is symptomatic. If the patient is not symptomatic, take your time. So what is the differential diagnosis? One thing is, we will think it as post ischemic, as discussed in the previous videos. Either this can be post ischemic, or this can be acute ischemia, acute ongoing ischemia. either ischemia or infarction. Okay, either ischemia or infarction. That is the second possibility. The third possibility, what is the differential diagnosis? So it can be uh, hypertrophic cardiomyopathy. It can be due to hypertrophic cardiomyopathy. What is the fourth possibility with inverted T waves? So that it can be post perimyocarditis. Post pericarditis, remember, post pericarditis inverted T waves. So these are nothing but the differential diagnosis of inverted T waves. One more thing is there, number 5. So ischemic acute ongoing ischemia, hypertrophic cardiomyopathy. Okay, and one more thing is there. Just remember, I think cerebral. I think it is cerebral T waves. Cerebral T waves in patient with hemorrhage, intracerebral hemorrhage. Okay, these are the differential diagnosis of inverted T waves. So how you will differentiate post ischemic? What will be there? Ischemia is over. So in this post ischemic inverted T waves, the amplitude of T waves in different leads will vary. You see here the amplitude in this, the amplitude in this, the amplitude in this, amplitude in this. It is not varying. They are similar. That means it is not post ischemic T waves. Now that is ruled out. So one is ruled out. Number two, it is acute ongoing ischemia or it can be infarction also. How do you say? So inverted T waves will be associated with ST segment deviation. ST segment deviation. Whether there is ST segment deviation in this ECG, yes, you can see here. There is ST segment depression here, and also you can see epsilon waves also. See, this is the epsilon wave. So ST segment depression is also there. That means T waves with ST segment depression of at least 1 mm should be there. Okay, 1 mm is there, and it is downsloping. Okay, so that means it is ongoing ischemia or infarction. So how you will differentiate? The patient can have symptoms. How you will differentiate? You just ask for troponins. If the troponins are elevated, then it is infarction. If they are not elevated, then it is ischemia. Or before that also you can confirm, you just give isosorbide trinitrate sublingually. Patient will improve with that. If the patient will improve with that isosorbide trinitrate sublingually, that means it is ischemia. And if the patient doesn't deploy upon those sublingual nitrates, that means it is more likely infarction. And the pain of infarction is uh, prolonged from 20 to 30 minutes, whereas the pain of angina will not last more than 5 minutes. It will be maximum 5 minutes. Okay, that is the difference between ischemia and infarction. So can it be hypertrophic cardiomyopathy? So in hypertrophic cardiomyopathy, the inverted T waves will be only in the chest leads, not in the limb leads. As you can see here, in the limb leads also you are seeing the uh, no, I am sorry, they can be limb leads also, but what you can see is there will be increased amplitude of uh, R waves. Associated R waves will be increased amplitude of R waves from V1 to V4 mainly. Okay, but you are not seeing any R wave here. See here, see here, see here. So it is not hypertrophic cardiomyopathy actually. Post pericarditis, diffuse inverted T waves you will see after an episode of acute pericarditis, and patient will have history of URTI, upper respiratory tract infection or lower respiratory tract infection. Coxsackie virus is very well known to cause acute pericarditis. Okay, cerebral T waves, the patient will be having stroke. Okay, so that's how you differentiate. Just keep in mind, whenever you are having just inverted T waves and the patient is symptomatic, send for troponins. If it is elevated, then it is NSTEMI. Differentiating STEMI from NSTEMI is important because the management is different in both. So that's about. So just two things you need to remember: ST segment depression and T wave inversion. But T wave inversion has broad uh, mainly five things are there. But on the top of your list, it should be heart related. Okay, one thing is brain related, that is cerebral TVS. But I, in the previous video I discussed here only. Now see, this is cerebral. How they'll be very gigantic, like this, gigantic inverted TVS. Okay, that is NSTEMI. That is NSTEMI. So I have discussed STEMI, we have discussed NSTEMI. Now we have discussed, I now have discussed the differential diagnosis of NSTEMI also. If it is depressed ST segment only, it can be ischemia or infarction, that too downsloping or horizontal. If it is upsloping, it is benign. that one you need to see. If it is down sloping or horizontal, send for troponins. If troponins are positive, that is infarction. That is about only ST segment. If T wave inversions are there, 5 possibilities are there. That too, if the patient is symptomatic, again you send for troponins. If they are positive, that is again NSTEMI. Okay. So what is the differential diagnosis of ST segment elevation, STEMI? Okay. So differential diagnosis of ST segment elevation myocardial infarction. So remember, mainly three. This is not a differential diagnosis. Mainly three are the differential diagnosis of ST segment elevation MI. What are those three? These three. Number one is pericarditis, acute pericarditis. Early repolarization pattern, very common in ECGs nowadays. If you see, this is very commonly found. Okay, and Brugada syndrome. Some patients you can see this Brugada syndrome. So acute pericarditis, early repolarization pattern, and Brugada syndrome. Three things you remember. So these three things are uh, what do you call, differential diagnosis of ST segment elevation. And one more thing was there, hyperacute T waves. I discussed in the topic of T waves. If the T waves are hyperacute, very much peak T waves, more than 5 amplitude in limb leads and 10 amplitudes in chest leads, they are called as hyperacute T waves. So what is the differential diagnosis of those T waves, hyperacute T waves? It is number one is hyperacute MI. Okay, just to revise, hyperacute hyperacute MI. Number two is uh, hyperkalemia, hyperkalemia, and number three is early repolarization pattern. So these three are the differential diagnosis of hyperacute, sorry, the stall T waves. Okay, and these three are differential diagnosis of ST segment elevation, ST segment, ST segment elevation. Okay. Okay, now we will discuss how you will differentiate between these two. So in acute pericarditis, this is important. Diffused ST segment, concave ST segment elevation will be there. Concave diffuse ST segment elevation, and PR segment depression. And this ST segment elevation, concave ST segment diffuse. Remember the words. It should be diffused, it should be concave, and the rest should be ST segment elevation. Diffuse concave ST elevations with PR segment depression, and it will spare these two leads, AVR and V1. This is one point you should remember. So pericarditis will spare two leads, one chest lead, that is V1, and one limb lead, that is AVR. Okay, this will spare. So this will be diffuse, but it spares these two leads, AVR and V1. So often it is because of viral pericarditis. So look for pericardial rub, that sound you auscultate by your stethoscope. And chest pain will be retrosternal, similar to MI. Okay, so you will take out ECG. How will be the ECG? One by one we'll see. See here, this, it will be like this. I will zoom it. So you are able to see elevated ST segment. See here, ST segment is elevated. V5 also elevated. All the limbs are having ST segment elevation, concave ST segment elevation. Almost all the leads, not not confined to a specific regional pattern which is found in myocardial infarction. So that means it is acute pericarditis, and it is concave. So concave. So if you draw like this, these are the two eyes, and this is a smile. So it is, this is a smile, it is benign. So it is due to pericarditis. And on your auscultate, you will have a pericardial rub sound you can hear in these patients. So that is the feature of pericarditis. So this is the ECG of pericarditis. There is a ST segment elevation, but it is concave. So this is one possibility. Now, next we will discuss early repolarization pattern. In early repolarization pattern, there will be J point elevation with notch or slur. This is important. With a notch or slur, and there will be concave ST segment elevation, again benign. J point elevation, notch and slur with concave ST elevation, mostly found in V2 and V5. It is a benign variant, common in young and healthy individuals. Benign variant, common in young and healthy, found in V2 to V5 leads. Notch and slur. So one thing I forgot to found, you can't see ST segment elevation spares AVR and V1 here. So yes, see here, it is not elevation, but instead is depression. Okay, so AVR is negative actually. So you can't see in V1 and AVR ST segment elevation. In all other leads you are able to see ST segment elevation. Here also ST segment, here also ST, three slightly elevated. Okay, here also elevation, here also elevation, 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 everything elevation. Only AVR and V1 they are not elevated, but they are depressed. So now we will see the early repolarization pattern. Remember, there are four types of patterns in early repolarization. So one is this, the commonest pattern, classical early repolarization without a J wave. There is something called as J wave in early repolarization pattern. So you can see there is J point elevation and there is ST elevation. So, and it is concave also. It is concave. Okay. And T waves are symmetrical. If you take from up to here, okay, T waves are symmetrical. So there is J point elevation with ST elevation, and that is concave. This is the commonest classic early repolarization pattern without a J wave. Now the second thing, you can see at the J point a J wave, see like this point. So this is also an early repolarization. Again there will be ST segment elevation, but it is concave. This is the second type of early repolarization pattern. Now here you can see there is a J point, but you can see slurring. Remember remember the WPW syndrome, you have slurring here, no, in the after the P wave. Okay, but in the early repolarization pattern you are slurring after the QRS complex, after the J point you are having this. So if you see slurring after the J point, then it is not WPW syndrome. Actually it is a type of early repolarization pattern, slurred QRS stroke without ST elevation. Without ST elevation, just there is slurred QRS stroke. That is one point. And these are approximately similar. Okay, these two are similar. Again you have just J point. Here there will be ST segment elevation, but here you will not find any ST segment elevation. Okay, that is the difference, that's all. But you have the J point. If there is J point and there is ST elevation, that is early repolarization pattern. If you see slurring, that is association. This is difficult sometimes. So if the patient is symptomatic in this type of, but it is again concave, no, it will be, it is not MI type of wave, it is concave. Okay, but if still if the patient is symptomatic, it can be probably pericarditis. Okay, and in ST, if you take an ECG, you will have diffuse ST. So remember these early repolarization patterns, these are very common, and they have called recently these early repolarization pattern as risk factors. In patients having repolarization pattern, you should search for risk factors like diabetes, hypertension, obesity, dyslipidemia. Okay, you should search for these risk factors in these patients. Okay, and in heart score, which is broadly used in EDs, it is given as 1 point. Remember, early repolarization pattern. Okay, so remember these things. J point, slurred downstroke of QRS complex, and the one is the classical just elevation of concave ST segment elevation. So this is an example of early repolarization pattern. So now you can see here in the two lead you are having ST segment elevation concave, and this is slurred actually ST segment elevation. And closely if you watch in some leads, you can see the J wave also. See, this is J wave, this is also J wave. Here you can't see J wave, you can show slurring of the downstroke. Okay, this type 4, this is type 2 early repolarization pattern. Okay, other things we'll look. This is 1 2 3. Okay, we have seen. And AVF, you see AVF again you are having slurring type, so this is type 3. So other things, other leads we will see. Other leads, V1 we are not having that. Yeah, this V2 and V3. So it is seen from V2 to V5 mainly, no, remember this point. Mainly in V2 to V5 you will see, mainly in V2 to V5 you should, these leads you should look for early repolarization pattern. So this is type 1, classical type 1 concave. This is the J point, and this is the ST segment elevation. And see here T waves are also more than 10 mm hyperacute type of T waves. Okay, and here like this again, here you have J wave here, J wave and concave elevation of system. So this is type 3, again J wave, but okay, again elevation, this is type 3 again. and here there is ST segment elevation. This is type 1. So this type, any of the 4 types, you can have this ST segment elevation. So this is early repolarization pattern. This is not actual MI. Okay, now we will see the third type, and fourth I will just discuss. The third type is the Brugada syndrome. What is Brugada syndrome? There is pseudo right bundle branch pattern. Okay, RBBB pattern, pseudo false, chord ST segment elevation. Chord means tented like this. Chord, cave like, that is chord. And possible T wave inversions also. Possible T wave inversions. Mainly you see in V1 to V2. You can include V3 also. Okay, V1 to V2. Pseudo RBBB pattern. What is right bundle branch pattern? Remember, marrow. So M pattern in V1 and W pattern in 1 AUL V5 V6. Pseudo RBB pattern, and there can be right axis deviation. No, in it is complete RBB. There will be right axis. There can be right axis deviation. Can be, okay. And chord ST elevation will be there. So pseudo RBBB with ST elevation with can be TUN there. So what is the clinical significance of that? These patients are risk of sudden cardiac death. It is a genetic channelopathy. And these patients are risk for sudden cardiac death. So these are patients to which you can, I think, insert ICD, intracardiac defibrillator, because they are at risk of sudden cardiac death. So that is one thing. Brugada, pseudo RBBB in V1 to V3 leads, pseudo RBBB right bundle branch, false right bundle branch block, chord ST waves, chord ST segment, can be T wave inversions. Okay. So left bundle branch or WPW syndrome, you will have white QRS complex. This will obscure ischemic changes. Chelates involved will be variable. This requires clinical context and biomarkers for triage. I said no during the discussion of left bundle branch block. Whenever you see a early, new left bundle branch block, always suspect MI in these patients, because left bundle branch block is always pathological. So new onset left bundle branch block, you should rule out MI by sending for troponins and doing the ECG. And if the troponins are negative, then you should suspect some structural heart disease and you should do 2D echo of those patients. Okay. So we'll see the Brugada. Again, Brugada syndrome has 3 types of Brugada. Okay. In that 3 type, the 1 and 2 are important. Okay. I'll discuss this 1 and 2. So pseudo RBBB, persistent ST elevations in V1 and V2. How that ST elevation can be, based upon that, the different type of that Brugada syndrome is divided into type 1, type 2, type 3, depending upon the type of ST segment elevation. This is chord, tented or cave type of ST elevation. Cave type of ST elevation. See, along with ST elevation, you are seeing ST T wave inversion also in lead V1. In lead V1. You can't say this as a early elevation pattern, because early elevation will be J point elevation like this. T waves will be like this. So in early elevation, it will be like this. But it is not like that. So it is something different. Cave type like this, an inverted T wave you are seeing. Okay. So ST segment elevation is more than 2 mm at least, and there is downsloping of ST segment. You can see there is downsloping of ST segment and inverted T wave. Chord ST segment. You say this as chord ST segment. Okay, this is type 1 Brugada. Type 2 Brugada. So there is saddleback. What is saddleback? So the ST segment was going downside, suddenly it will come upside for some time, and again then it will continue its journey to downside. Then there will be T wave, biphasic T wave. See, the T wave is biphasic, upright or biphasic. It can be. Here it is, I think it is upright T wave only. Okay, so that is saddleback type of ST wave configuration. Saddleback is the T wave was going downside, again, for some time it will come upside, again it will go downside. So that is saddleback. Saddleback fever of dengue you have heard now. So the fever will drop for some time, again it will come back. That is saddleback. So this is the ST. There is ST simulation of at least 2 mm. Yes, it is there, more than 2 mm in the lead V1 and V2. It is saddleback type of pattern. This is not early repolarization pattern. Okay. So type 3 we have not discussed, no? So we'll discuss in this figure. See, this is type 1 Brugada, core type of ST7, core cave type, or you can say there is a solution again with along with this ST segment depression and inverted T wave. You will have inverted T wave in V1, V2 leads mainly, but in this figure he has shown V3 also. So here you can see saddleback type of ST segment changes in mainly V1 and V2. V3 you are not seeing. So type 3 Brugada, what is the difference between type 2 and type 3 Brugada? Just there is the difference between amplitude. The elevation in type 1 Brugada, amplitude of ST segment elevation in type 2 Brugada is more than the amplitude of elevation in type 3 Brugada, but it is saddleback only. See the amplitude, it is this much, and here it is touching this and this one saddleback is touching downside. So the difference between type 3 and type 2 is not much. They are both saddleback only, but the difference is only in the amplitude. The difference is only in the, again you are seeing in V1 and V2, which you are not able to appreciate. Okay, so mainly you will see in V1 and V2. So just to remember, either coved, COVED, coved or saddleback. We will see in ECGs now. See here. Okay. Before going to that V1, V2 lead, see here the ST segment depression you can see, but this is in lead 2. The J point is depressed, but the ST segment is upsloping, so it is B9 actually. It is B9 because the ST segment is upsloping. ST segment is upsloping. Here also the ST segment is upsloping. Okay, it is B9, upsloping ST segment B9. Mainly common cause is tachycardia. See the number of box. It is approximately 3. So 300 by 3, 300 is equal to 100 beats per minute. Now, tachycardia is there. So probably that is the cause for this ST segment depression. Okay, upsloping is B9. Remember like this, upsloping is actually hard. So hard thing is ischemia actually, and downsloping is easy, or horizontal is easy to run. So downsloping and horizontal is easy to run or walk, but upsloping is hard to run or walk. But in case of ischemia, it is opposite. Upsloping is hard actually, but it is B9 in ST segment depression. Easy to walk is difficult in ST segment depression. That's one. Like this, you can remember this 3 types of ST segment depression. So easy walking is actually difficult, and difficult walking is actually easier. Okay, in ST segment depression. Okay, so you can see type 1 Brugada in V1 and V2 leads. Okay, along with T-wave inversion, code type of elevation of ST segment. 3 is approximately normal only. 3, 4, 5, 6, they are normal only. Okay, so that is type 1 Brugada. Now we will see another lead, type 2. Okay, again you are seeing this is also tachycardic ECG. See, ST segment is upsloping ST segment. Here also no, yes, here also you can see somewhat upsloping ST segment. Now you see here this is saddleback. This notch you can see, no, this is saddleback. So this is type 2 Brugada in V1 and V2. You can't see in V3, V4, V5, V6. So it is saddleback Brugada, and the T wave is biphasic. Here you can see. I will zoom this. The T wave is biphasic here. Here also it is biphasic only. Okay, biphasic. Whenever the T wave is biphasic, you will see the terminal part. So terminal part is what do you call, downside. So you will say it as inverted T wave. Whenever the T wave is biphasic, you see the terminal part. Wherever the terminal part points, that will be the direction of T waves. Here it is downside, so it is inverted T waves. Okay, so this is type 2 Brugada. These patients are at risk of sudden cardiac death. So these are the 3 important differential diagnosis of ST segment elevation. Acute pericarditis, early repolarization pattern, very much common, and early repolarization pattern, acute pericarditis, and Brugada syndrome. Remember this 4 types of early repolarization pattern. This is one classical. This is J will be there here. Either J or slurring will be there. So these are two. Here will be elevation, here there will not be elevation. Okay. Early repolarization pattern. Acute pericarditis. You can see diffuse concave. One more thing I have forgot to tell. There should be PR depression, no? PR segment depression. We should see PR segment depression in pericarditis. We have not seen, no? Let us see whether there is PR segment depression here. PR segment depression. Yes, you can see here there is PR segment depression here. This point, this lead you see, there is PR segment depression in two as well as in one lead. Okay, three is three you are not able to make. Here you can see it is depression. Okay, so in one and two you can see there is PR depression. Okay, or else you are seeing just flat means normal only. So here you are able to see PR depression. So more commonly it is diffuse uh, ST simulation. Now it is not early reparation because early reparation will be mainly in chest leads from V2 to V5, but you are seeing this in limb leads also. Okay, so that's about the differential diagnosis of NSTEMI and STEMI. So by this we have completed the topic of acute coronary syndromes. In the next video we will discuss about other critical ECG diagnosis like electrolyte disturbances, drug effects and autonomic tone, digoxin effect, voltage alternance, electrical alternance, and along with that we will discuss stress testing, or that is treadmill test, okay, or chemical stress testing, and giving okay, and Holter and implantable. This will be the last video. The coming video will be the last video of the ECG. So thank you.